being here and taking the time for this session. We know the transition of the E700 ventilator has been challenging, and we have heard your concerns and frustration, especially around the alarms. So I want to say that what you are experiencing now is expected, especially for any EMS services that moves from manual ventilation using BVM to a mechanical ventilation using transport ventilator. It's not specific to the E700 ventilator or any brand, as all ventilators work on the same core concept and principles. Ventilation modes, settings, and alarms, all of them are the same, including those ventilators in ICU. They have the same concept even for how pressure, volume, and flow are measured and controlled. Today we are going to focus on the biggest headache you have dealing with, which is the alarm. Why they happen, what they mean, and what to do when they sound. Toward the end of the session, we will also spend some time on CPAP and BiPAP. We will intentionally trigger alarms so you can see what exactly changes on the screen and how to respond based on that in the field. The goal today is to break down the main concepts behind alarms and mechanical ventilation, and to help connect what you already know about ventilation to what the ventilator is showing you, so it feels easier to manage and control those alarms in the field. So before starting the practical part, I would like to explore some concepts of the alarms in mechanical ventilation. So for now, you can turn off your ventilator to preserve the gas. So just feel free to turn off your vents, and once we start the clinical part, we will turn it on. So when we bag a patient with a BVM, we are basically controlling everything manually. We decide how big the breath is. This is the tidal volume. And we decide how fast we give that breath or how much flow we use. And this is the flow rate. And we decide how long the breath lasts. So that's the inspiratory time. So we feel, once we bag the patient, we feel the resistance in our hands. We watch the chest raise and we adjust accordingly. The ventilator does not change what happens in the lungs. What it changes how much visibility we have into what's happening in the patient's airways. So when we move to a ventilator, all of the same things are still happening, but now they are being measured precisely by sensors. So the ventilator continuously measures pressure, flow, and volume on every breath. That's why the alarms exist. They are there to give us information and to make ventilation safer and more controlled and more consistent. With the BVM, if the lungs are stiff, we feel the resistance on the bag. We don't know how much pressure we are generating or whether that pressure is safe or not. And we don't know if the volume that we are delivering is safe or not. The ventilator gives us the information. And when something starts to move outside of the limits that we have set, it alerts us. Each alarm is simply pointing us towards something that needs attention, either the patient or pressure, volume, rate, or circuit, leaks, patient's efforts. So every alarm points us towards specific things. So before we look at the screen or start touching the settings, always keep in mind that the ventilator doesn't have clinical judgment. It doesn't know the patient, it doesn't know the diagnosis, either it's congestive heart failure or COPD or trauma. All the ventilator knows is what it can measure at the airways. So that's why the sensor lines are located at the end of the patient circuit. So those sensor lines, basically here, this is where all data the ventilator receives from. So the ventilator only measures what happens in the airway. They don't know what's going on with the patient or what's the disease that caused any changes inside the lungs. So that's why the location of the sensor lines are at the end of the patient circuit, close to the elbow joint. And then we connect the patient to the vent, either by mask or the ET tube. In any case, if we have an interruption or if we have any, if the ET tube or the tube that we use for the mask disconnected from the elbow joint, it may lead to interrupt the pathway of the flow to the patient and the flow from the patient to the circuit. In that case, if there is a leak that occurs, let's say, after the elbow joint, in that case, once the patient exhales, the air will not reach this part of the circuit, which is the sensor line adapter, this part. So that's why during inhalation and exhalation, all air will go from the vent to the patient through this part. And at the same time, when the patient exhales, also the air will reach this level, where we connect the two sensor lines to the vent, as you can see here. So we have the bar, and we have the lower connection. So in this case, we always need to make sure that those lines are well connected, because in any case, if any of those tubes are disconnected, same as now, what happens here? It will show alarms, PCI alarm. It's not only the tube or the mask, it's also the components of the circuit itself. So that's why we need to make sure that those lines are well connected. And at the same time, on the opposite side also, because if we move that sensor line from the back side of the vent, what happens to the readings? If you can see here, the numbers are in thousands. So in that case, it will interrupt the readings. So that's why we need to make sure that those sensor lines are well connected. So what exactly the ventilator measures? So there are three parameters. Every ventilator will measure those things. As we said, regardless the brand or regardless the type of ventilator, even those in ICU, they have the same way of measurement. So they measure pressure, flow, and volume. Pressure, flow, and volume. So in any case, if we keep in mind those three parameters, if anything changed or anything went out of the limits that are set, we will have alarms. So that's why everything you also see on the screen here, in this part, it's basically calculated from those three measurements: the pressure, flow, and volume. So when the ventilator alarms, it's not malfunctioning, it's not broke, or it's not causing issues to us. It's only telling us that one of those measured values changed beyond the limits that we set. So now, again, let's connect this directly to how we already ventilate in the field when we bag a patient. So if the bag suddenly feels tight, we ease up. And if the chest raise looks poor, we squeeze harder or adjust to deliver more volume. And if the patient starts breathing faster, we slow down and adapt the rate. So we constantly reading what's going on in the lungs, but without numbers, without alarms. So the ventilator does the same thing. Instead of feeling the resistance, it shows and it measures the pressure in the airways. And instead of watching the chest raise, it measures the volume that's delivered to the lung. So So the difference here is the visibility, not the control. Because all ventilators, they don't take the decision making away from us. It's giving us a clearer feedback about what's happening at the airways. So when we bag, we don't know how much pressure or volume we are generating. We just know that the bag feels tight. The ventilator determines the required pressure to deliver each breath. So when, let's say, let's explain the balloon concept. So if we have two balloons, one is stiff and straight, and another balloon that's loose. And we want to inflate both balloons with the same volume, let's say 500 ml. What do you think about the pressure inside those balloons? Do you expect the pressure to be higher in the stiff one, or they will be the same? So the pressure here is the measurement of the force that's take or it needs to deliver that volume. So if the balloon is strict, in that case you need more pressure or you need more force to deliver that volume to the lung or to the balloon in this case. On the opposite side, we need less pressure to deliver the same volume, but the pressure here is less and the pressure in the stiff balloon is higher. So this is basically the concept of balloons in mechanical ventilation. So those alarms exist to prevent silent problems like lung injury, hypo or hyperventilation, especially during transport when patient condition can change very quickly. So that's why once we control those parameters, once we control the pressure, once we control the volume or the flow, we are able to prevent lung injury and we are able to prevent hyper or hypoventilation. So that's why the outcomes of ventilating a patient with a transport ventilator, based on the studies, they improve the outcomes. Why? Because the ventilation is controlled and the ventilation aligns with alarms and it shows us what's happening. So the main idea or the main skill that we need to do is to be able to navigate and to check what's going on with the patient. Because the main difference between ventilating a patient with mechanical ventilation or BVM is basically with BVM it's easier to use, but at the same time we don't know what's going on with the patient. The risk of injury is higher and the outcomes could be much lower. Even though we have high experiences, even a lot of recent studies, they show that manual ventilation, even for people with 20 years of experience, they still either hyperventilate or hypoventilate a patient. Why? Because we don't have readings, we don't have any limitation of what we are doing during the ventilation. So I want you always to remember that when an alarm sounds, a measured value crossed a preset limit, and the screen will show you exactly what changed. So every time when an alarm happens, don't frustrate, but ask yourself 3 questions every time. What does the alarm indicate? Does it indicate anything related to the circuit? Is it a leak? Or it's related to the source of oxygen? Is it a high oxygen pressure or low oxygen pressure or no oxygen? Is it related to the patient? If the patient complains from those diseases that may reduce the lung compliance or the lung elasticity, same as acute respiratory distress syndrome. So after we check what's the indication of that alarm, then we should address, what should we address first? Is it the patient? Is it the circuit? Or is it the settings? Or maybe it's related to the patient. The next step is to check which value changed and what could explain that change. Is it related to the airways? Is it related to the alarm limits that we have? Or if the patient is coughing, for example, or sneezing? Or the lung mechanics changed during the transportation? Is it getting worse for the patient? How about patient's effort? Maybe they start with spontaneous breath and then suddenly they stop breathing, or the efforts are less. So all of these changes will be measured. How they are measured? Again, from those sensors. Because they are very close to the patient. That's why always keep in mind that this part, which is the elbow, needs to be well fixed and connected, because this is the most common cause of leaks, in case if it's not fixed well and not secure. Because with movements during transportation or the movement of the patient, it may lead to losing the connection here, which is the elbow joint. So always make sure that it's well fixed when you connect it to the tube or the mask. So now that we understand that the ventilator, how the ventilator measures those parameters and why it alarms with those changes, the next step is the main important part of troubleshooting the alarms, is to learn how to read the scan, how to read the screen, and how to scan it, because this is where most frustration comes from. So one of the main advantages we have in E700 is that everything we need during ventilation comes in one screen. So we don't need to navigate through different windows to find out what's the reason behind that alarm, or what changes could we do. In this setup of the screen on the E700, we have everything we need in one screen. So we have to get the benefit of that. How to use that benefit? So first of all, if we have everything in one screen, it makes it easier for you to make some links and connections of what we have on the screen, which make it way faster than any transport ventilator, because we have everything in one screen. So that's why if we master how to make the connections and how to read what's going on the screen, it will be way easier for you to identify the reason behind the alarms. So what we have here, first part here, it's live monitoring parameters. So believe me guys, this is the most important section on the screen. Why? Because this is the data that we receive during ventilation. How do we get these data? Again, from this sensor. So that's why, in case if you have any issue related to the connection or related to the airways that you use, in that case, the readings will be interrupted here, because the air or the exhaled air was not readed by the vent, because the leak prevented the full exhalation to come to this part. So in that case, the readings will be interrupted. So that's why the first thing we do is to make sure that the connection is well secured. So this is the first part. This is the live monitoring parameters, which is the main one. So those are data are updated with every breath. So that's why this is the main part. The second one is the ventilation settings. So basically, this is what we ask the vent to do. So those are the settings that controlling the breaths that we ask the ventilator to deliver to the patient. So that's why this is what you ask the vent to do, and this is the result of what's going on with the patient. So in case, let's say, before talking about mechanical ventilation and so on, we have to identify that we have three different types of breaths in mechanical ventilation. The first one is controlled breath. Controlled breath is the responsibility of the ventilator to deliver. So those settings that we have, they are the settings for controlled breath that we ask the ventilator to deliver. For example, tidal volume, 500 ml. The rate is 10. So we ask the vent to deliver 500 ml 10 times per minute. So this is the controlled breath. So in case if the patient doesn't breathe at all and doesn't have any effort, in that case, what happens to the readings? what happens to the readings in live monitoring parameters? They're supposed to match what the ventilator is delivering. Let's say if we set tidal volume at 500 ml. So in that case, in live monitoring parameters, we could check here the exhaled tidal volume. So let's say, what's the meaning of tidal volume? Tidal volume basically is the amount of air that reaches the patient with every inhalation. So if we deliver 500 ml, so what do we expect during exhalation? We expect 500 ml. So in that case, if we deliver 500 ml for those patients who cannot breathe, we expect 500 ml. But if we deliver 500 ml for those patients who already having also together with the controlled one, they have some sort of spontaneous breath or another assisted breath. It will be shown here the result of the total breaths or like the updated number. So let's continue. So the first type of breath is the controlled one. This is the responsibility of the vent. So those settings are for the controlled breath. The second type is spontaneous breath. So as you know, in some modes, same as in CPAP or PiPAP or even SIMV, we have spontaneous breath. So those are the responsibility for patients. So they are responsible to take either deep breath or shallow breath. So in that case, those breaths, the ventilator doesn't have anything that could help during that breath. The third type is the assisted breath. Assisted breath means in case if the patient tries to make some respiratory efforts, the ventilator using the trigger sensitivity, it will detect that breath, and then in assist controlled ventilation, it will support that breath by delivering 500 ml, the same as we said for the controlled one. So in that case, live monitoring parameters, it's not only what we set, but also it will combine and it will show you all types of breaths according to the ventilation mode. Let's continue now with the next part here. So as you see here, this is VT or tidal volume. The next one is the rate. So during each inhalation, the ventilator receives 500 ml. And we ask the vent to deliver 500 ml by 10. So in that case, the minute volume that we have here, the third parameter, this is the result of multiplying the tidal volume by the rate. And it's automatically calculated. So in case if we increase or decrease the tidal volume, okay, it will immediately calculate what's the minute volume that we are applying to the patient. So what does it mean, minute volume? Minute volume means this is the total volume that the patient received during 1 minute. This is not related to mechanical ventilation only, but also it's related to BVM. So that's why when we manually ventilate the patient, we are controlling that by ourselves. We decide how big the breath we deliver. But here in the vent, we decide and we select precisely what's the total volume that we want to deliver. And in BDM, we decide how many breaths we are delivering per minute. And at the same time, the vent will do the same. It will decide how many breaths you are delivering, and you may adjust that according to your patient. The total here, the minute volume, this is the total volume during 1 minute. So how to calculate that? It's automatically calculated by multiplying the tidal volume by the rate. When you ventilate your patient, we have two equipments that we use. We have the oxygen saturation and we have the capnography. So when we talk about capnography, so this is an indication of the amount of CO2 that were cleared out from the patient or from the lungs. So in that case, if you always make a link between the minute volume to the capnography, because in case if you are washing too much CO2, so it means that you are hyperventilating your patient. And if you are washing less CO2, so you are hypoventilating your patient. So that's why if you need to adjust the minute volume, you have two options. Either to adjust the tidal volume or to adjust the rate. So let's say if your patient is breathing too fast or tachypneic, so in that case, we could reduce the rate to minimize the minute volume. And if you are not ventilating well your patient and the CO2 is too high, and we need to clear out more CO2, in that case, we could either adjust the rate or volume. But I want you to always keep in mind that if we increase the tidal volume too much, according to the patient case, it may lead to increase what? The peak airway pressure. Why? Because always remember the balloon concept. So if we have the same volume, 500 ml, for a patient with acute respiratory distress syndrome or ARDS, in that case, the ability or the elasticity of the lung is reduced. So in that case, the patient will have a higher peak airway pressure. We could see that in different cases, like ARDS. We could see that also in emphysema, or we could see that also in pulmonary edema, pulmonary fibrosis. So the ability for the lung to expand or the lung compliance for that patient is reduced. So in that case, the same tidal volume that you deliver to another patient was fine for that patient, but for this patient, because the lung is stiff, it may lead to have what? A higher peak airway pressure. So that's why we could think about minimizing the volume, and we may also increase the rate to compensate the reduction of the minute volume. For example, now we are delivering 500 ml and 10 breaths per minute, and the total minute volume is 5 liters. So if we want to decrease the volume, to decrease the peak airway pressure, let's minimize it to 4, for example. And at the same time, we could increase the rate to 12, and in that case, the total will be around 5. So that's how we are able to manage the volume and the pressure. Explain, but just to make sure that we are in the same path. All right, so okay, so peak airway pressure. When we ventilate a patient, and as we said, this is like monitoring parameters, this is one of the main sections that you need to keep in mind. So peak airway pressure. As we said, it depends on the pressure, the maximum pressure that's applied during each inhalation. So during inhalation of 500 ml for one patient, let's say the patient that I'm having now, it's generated 17 centimeters of water. So that 500 ml led to 17 centimeters of water in peak airway pressure. This is the maximum pressure during each inhalation that we deliver. Let's say I'm having another patient, but that patient has a stiff lung, and I want you to do that together with me, with your vent. So I'm applying a pressure on the test lung, same as now. So during inhalation, just put some pressure on the test lung. So what happens now? Which alarm do we have? High peak airway pressure alarm. Why do we have this alarm? Even though, like, if you check now, I'm putting a pressure on the lung. So in that case, the lung here for the patient that I'm having right now is stiff. So what happens to the airways once the vent tries to deliver the 500 ml? The peak airway pressure increased. So instead of 17, now I'm having it at 30. So why? And at the same time, let's check the other side here, the exhale tidal volume. So I set the vent to deliver 500 ml and end up to have 280 ml for the exhale tidal volume. So why it doesn't deliver 500 ml? So when we talk about having one screen, so this is the advantage. So as we said, we have live monitoring parameters, we have the settings here, ventilation settings, and we have alarm limits. Those alarm limits are also very important. Why? Because every ventilator, even those in ICU or other transport ventilators, this is a feature for safety for the patient. Why? Because here where you set what's the maximum allowed level for peak airway pressure, for example, for the pressure. And here we set what's the maximum allowed minute volume. And at the same time, what's the lowest allowed pressure? And what's the lowest minute volume? So always, when we talk about peak airway pressure, or what's the maximum pressure during each inhalation, always link the pole peak to Pmax and Pmin. Why? Because if 500 ml generated a very high peak airway pressure, same as now, so the Pmax, which is the highest limit, 50. So in that case, the ventilator will cut that flow and limit the volume not to reach 30. So that's why once it reaches the highest allowed limit, we have the peak airway pressure. And the opposite, in case if we have, for example, a leak that led to have the peak airway pressure to reach 3 centimeters of water here in Pmin, in that case, it will activate Pmin, it will activate low flow alarm. So once any of those limits are reached, in that case, the ventilator will stop the peak airway pressure until the limit that you have here. And at the same time, it doesn't allow the full breath to be delivered. That's why instead of having 500 ml as intended by the settings, it will cut that breath. So in that case, it will deliver less tidal volume. So that's why, as I said, in case if we deliver 500 ml, we confirm that the patient is exhaling 500 ml. And in case if we have high peak airway pressure, this number will be less. Why? Because the peak airway pressure reached the maximum allowed pressure, and in that case, it will trigger the alarm, and then it will cut that tidal volume to not to reach a higher level. So, what's the solution here? So, before that, I would like to ask you to write down in your notes the maximum peak airway pressure, like the maximum safe airway pressure, is 35. So in any case, try to not to reach 35 in peak airway pressure. So 35 is your upper limit to make sure that you won't hurt the lung of your patient. So if the peak airway pressure above that range, above 30, let's say 45, 50, 60, and so on, there is a possibility for lung injury. That's why during mechanical ventilation, we try to minimize that pressure. So that's why we try to keep it below 35. So in this case, if let's say if you if your patient reached 30 and the alarm is triggered and the tidal volume is cut, in that case, you will be able to increase the higher limit of the pressure. So instead of having 30, you could increase it to 45 to 55. So in that case, you give some gap between the highest peak error pressure and the alarm limit. But always, as I said, always keep in mind that you have to keep the peak error pressure below 35. So now, in this case, I'm going to do the same way. I'm going to deliver 500 ml as tidal volume, and we want to compare the peak error pressure and the exhaled tidal volume. And I want you to do that the same in your veins, so you could see the changes. So the Pmax, I set it at, let's say, 55. And now I'm delivering 500 ml, and I'm pushing on the lung to give more pressure. So the peak error pressure now, 28. I'm adding more pressure. Now it's 34. And what's the tidal volume here? 480, 460, even though the peak error pressure at 40. So in this case, there is no alarm, but still within the safe peak error pressure. And the tidal volume here is full. Why? Because the ventilator didn't cut that tidal volume not to exceed the level here. So that's why Pmax and Pmin, those are the safety limits for pressure. And that's why they are useful during the ventilation. It's not always required for you to increase that limit, but in case if you have it because of, for example, some patients, once they cough, it may lead to increase the peak error pressure once, for example, or twice. Or in case if they sneeze, also it could increase the peak error pressure. So in that case, you give some gap when you increase it. Some of those alarms could happen just once, and then they disappear. So in that case, it means that something changed and temporarily, and then it's moved. In that case, you don't need to do anything, but just for like a more quiet ventilation, you could increase the Pmax to 45 or up to 55, do not to exceed that level. Same way, we have other limits for minute volume, MV max and the MV min. So those are the highest limit for minute volume and the lowest limit for minute volume. So where do we need to compare in live monitoring parameters? Could you please tell me? So the MV max and MV minimum, MV min and MV max. So if we talk about minute volume, where in the screen should we compare the limit, or should we compare the value of minute volume with those limits? As I said before, always check live monitoring parameters. Don't check the settings. Always check the live monitoring parameters. If the minute volume that we have here, the exhaled minute volume, you see here, MVE, this is the exhaled minute volume. So this is what you compare. We compare minute volume or exhaled minute volume with minute volume limits, the highest and the lowest one. So in case if the value here is within this range, you won't have any alarms that are linked to minute volume. But in case if it reaches the highest limit, it will alarm high minute volume alarm. And if it reaches the lowest limit, or MV min, in that case, it will indicate low minute volume. So what happens here? Let me give you some examples of those alarms. I believe that the majority of you experience low minute volume and high peak airway pressure alarm, right? Like those two alarms. But less common to experience high minute volume alarm. Why? Because in the average minute volume range for adults, it's between 5 to 7 liter per minute. This is the average for adults. Let's say in some cases with patients with tachypnea and they have respiratory distress and they are trying to breathe deeply. In that case, it may lead to have hyperventilation. So the minute volume for some cases, it may reach 10 liter per minute or 12, but it won't reach above that level. So that's why the ability to have high minute volume alarm is limited, because already the default MV max is 30, which is too high. But I would say that you experienced low minute volume alarms. Why? Because minute volume alarms, if we are ventilating a patient on invasive ventilation, let's say on assist control ventilation. For assist control ventilation, we guarantee that the patient will have the same as the default settings, let's say 5 liter per minute in minute volume. So in that case, even though if the patient doesn't breathe at all, the ventilator will take care of the controlled breath and it will guarantee 5 liter per minute as minute volume. But in case, if we are on controlled mode, like assist control ventilation, and the number here for exhaled minute volume drops to 1. In this case, what does it mean? It means that there is a huge leak. Why? Because in case if we set the vent to deliver 5 liter, the ventilator will deliver that 5 liter and it will guarantee that 5 liter. But in case, if the tube is misplaced or not positioned well or disconnected, for example, or the mask, for ventilation, let's keep talking about the airway. I believe you use AirQ3, right?
Yes.
Yeah, with AirQ3, the ability to have leak is higher than the ET tube because of its position. That's why we have to make sure that it's placed well during ventilation, because the risk of misplacing or like replacement of the position is high. So that's why if exhaled minute volume dropped to 1, same as the MV min, so as we have this limit, the default limit, it's at 1. In that case, it will activate low minute volume alarm. So this is basically when we talk about controlled breath. So this is easier for you to notice that there is a leak, because we guarantee 5 liter per minute, and here it shows less. So what does it mean here? If the connection from the patient, so we expect the patient with, first of all, the ventilator will deliver 500 ml to the patient, and then during inhalation. And during exhalation, the ventilator will expect the same amount to reach this area where the sensors are located. In case if the readings in live monitoring parameters shows less numbers than the expected or than the amount that was delivered, in this case, the ventilator will detect that there is a leak. Why? Because it's dropped below 30% of what you have delivered. So in this case, the ventilator will try to compensate that leak up to 30% of that leak. If we talk about CPAP, as I said before, on CPAP, we expect the patient to breathe spontaneously. On CPAP, the ventilator doesn't send the breath. It only maintains a continuous positive airway pressure. But as you see, I'm going to switch to CPAP. As you see here, we don't have tidal volume. Why? Because we are not delivering a breath. We are just keeping a continuous pressure during inhalation and exhalation. So in this case, where could you find out if that minute volume is good for this patient or not? Again, the live monitoring parameters, because those parameters will be present in all ventilation modes. So if you want to check if your patient is breathing or if those breaths that the patient are taking are efficient or not, what to check? Check the exhaled tidal volume. Check the exhaled minute volume. So for example, if you are ventilating an adult patient with a weight for, let's say, 70 to 80 kilograms, and in that case, the average the average tidal volume is supposed to be around 500 to 600 ml. So if you check here on CPAP that the exhaled minute volume is below that limit, so in that case, it means that the patient is breathing a shallow breath. Why? Because it's superficial breath. They are not deep. The rate could be high because they are breathing very quickly, very like in a fast rate, but they are not efficient. Why? Because the exhale tidal volume is very low. I will explain later what to do in this case, but I just want you to understand that the live monitoring parameters is where you have to evaluate and to check what's going on with your patient. Any questions so far? All right. So just to make it easier for you to remember, the ventilation settings, those are what we ask the ventilator to do. Live monitoring parameters is what's actually happening at the airways. So these values that we have here in live monitoring parameters, they reflect both ventilator delivered breaths based on those settings and patient spontaneous breath at the same time. So that's why if the patient doesn't breathe, you will see similar numbers for minute volume and rate and tidal volume. But in case if your patient has some spontaneous breath, in that case you may see higher number. So that's why you always link that to the capnography and the oxygen saturation. So as we said, if you check here, we have exhaled minute volume and we have exhaled tidal volume. So this is the way how all ventilators measure those live monitoring parameters. They are all only based on the exhaled parameter, the exhaled air. So in that case, it will give us a clear idea about what's going on with the airways. So when we talk about high peak airway pressure, so I would like to start with high peak airway pressure. So this is the highest airway pressure measured during each inhalation to deliver a breath. So clinically, this tells us how hard it was to push the air into the lung. So this is the ventilator version of how stiff or easy the bag feels in your hand. So as we all manually ventilate, and we feel the stiffness or the ease of bagging, so it's the same as if you check what's the airway pressure. So if the bag is stiff, it means that the peak airway pressure is high. If the bag is fine and smooth and elastic, in that case, the peak airway pressure is low. Always keep in mind, the higher the peak airway pressure level, the higher the chance for lung injury. So that's why we try to keep it below 35. What are the most common reasons behind high peak airway pressure? So first of all, we could say it's related to the patient. If it's related to the patient, you could see that in bronchospasm, if the patient has bronchospasm. For those patients on COPD, for example, what happens in COPD? It leads to have narrowed airways because of the bronchitis and because of the inflammation of the airways. So it leads to it will lead to decrease the diameter inside those airways. So it makes it harder for the volume to reach the alveoli. That's why, in that case, in case of bronchospasm or bronchitis, the peak airway pressure could be higher than other patients. Secretions. So if the patient has a disease that leads to increase the secretions, always check that the secretions are not blocking the airways. So always make sure that the airways are clean. If you need to use suction just to clean the airways, that will help you to reduce the peak airway pressure. In any case of keeping or biting the ET tube or the airway. So if the patient is biting because of the pain, if they are biting the airway, also it will narrow the diameter of the airway. So in that case, it will increase the peak airway pressure. Another cases, if we say the patient has an issue related to lung stiffness, like congestive heart failure, ARDS, or pneumonia, also it will lead to increased peak airway pressure. If we perform CPR and we use Lucas device for mechanical compressions, in that case, let's switch to CPR. I want you to also to switch together with me. So as long as you use Lucas device during CPR, so in that case you have to use the intubated mode. So if you notice here, the Pmax limit is 60. Why? Why it's not 30, same as others? Because in CPR, any chest compression, it will lead to increase the peak airway pressure. Why? Because we are forcing mechanically the chest downward, and it will lead to increase the pressure inside the alveoli and inside the airways and inside the chest in general. So that's why the peak airway pressure, we would expect a higher peak airway pressure during CPR. Same concept if we say about the exhaled tidal volume. So if we set the tidal volume, because here, as per the protocol in AHA, the tidal volume is supposed to be 500 ml or to have enough volume to visualize the chest raise. So in case if anything happened regarding the pressure, the peak airway pressure, and high peak airway pressure alarm is activated, this could lead to have a less exhale tidal volume. Why? Because the ventilator will cut that breath until it reaches 60. So in that case, if we increase the Pmax more than that, let's say 70 or 80, it will allow the vent to deliver full breath. Because otherwise, as per safety limitation of those alarm limits, if the peak airway pressure in live monitoring parameters reaches the highest limit, in that case, the vent will cut the tidal volume. So that's why, if the high peak airway pressure is continuous, in that case, you just increase the Pmax level. So in that case, you give the ability for the vent to deliver the full 500 ml. So in any chest compression in CPR, it will lead to have higher peak airway pressure. But if you use Lucas device, it will increase it even more because it's a mechanical compression. And the mechanical compression may lead to have a higher peak airway pressure. So if we compare, for example, a manual chest compression with a high peak airway pressure, it will be lower if we do the chest compression manually. Any questions so far? All right. Do you guys have any question related to the alarm limits? Because, like, in case if you experienced anything related to those alarms, we can explain it to you now and make it more clear. So now let's switch to, I'm going to switch to CPAP mode. So, yeah. So when we talk about CPAP, the concept of CPAP is the same if we use disposable CPAP or if we use CPAP on mechanical ventilators. So the concept is the same. It's a continuous positive airway pressure during inhalation and exhalation. So what's the main goal for CPAP? The main goal for CPAP is to maintain the airways and the alveoli open to improve the gas exchange during inhalation and exhalation. So during inhalation, once we have a continuous pressure and the patient is able to inhale, in that case it will fill the alveoli. So once it fills the alveoli, the surface inside the alveoli will allow to have a more efficient gas exchange between CO2 and O2. So that's why we could check the oxygen saturation, and within a few minutes you will see the improvements. So what's the main concept here of having CPAP continuous during inhalation and exhalation? So as we said, during inhalation, the alveoli will remain recruitment and they are open and patent. But to prevent those alveoli to collapse during exhalation, that continuous pressure will keep the alveoli open in a way that it keeps the gas exchange continuous. So as per concept, it's the same in ventilator or disposable CPAP. But the difference here is that disposable CPAP, they don't have alarms or sensors that indicate that any kind of drop of that pressure, because the concept requires us to keep a constant positive airway pressure level. So if we set, for example, 10 centimeters of water in CPAP, it needs to be maintained without any drop during inhalation and exhalation. So in that case, how does all ventilators prevent that drop during inhalation? So when the patient inhales, there will be a drop of that pressure. So the ventilators, because they have sensors, they will measure that drop, and at the same time, it will compensate for that drop in a way that keeps the level of CPAP continuous and constant, the same level that you set. So for example, if we set 10 centimeters of water, in that case, it's supposed to be continuous within the same level. During inhalations, once the patient inhales, the pressure will drop. Once it drops, the ventilator will detect that drop. So in that case, it will compensate that demand to keep it maintained and constant with the same level. But when we talk about disposable CPAP, this feature is absent. So the efficiency of CPAP in terms of keeping the main concept for CPAP constant and continuous, the disposable CPAP doesn't have that feature to compensate. That's why it keeps the pressure continuous, but it doesn't have alarms or it doesn't have sensors to monitor or compensate for that drop. So that's why in some cases it may feel more comfortable for those disposable CPAP once they use those disposable ones, and at the same time you may feel like the oxygen consumption for the vent is higher than disposable one because of the compensation mechanism. So this is not only for E700, this is for all mechanical ventilators, even in hospitals or in any transport ventilators, because as we said, like the concept, the main concept, like the medical concept of CPAP is to keep a constant, continuous positive airway pressure. So that's why the consumption will be based on the demand. So in case if the demand is higher, the compensation is higher, and in that case, the consumption will be higher. So let's discuss CPAP as per protocols, like as per global protocols in terms of CPAP. So as we said, the first thing that we need to check before performing or applying CPAP to our patient, we need to make sure that the patient is well-oriented, conscious, able to have spontaneous breaths. Even though if you have those patients with high respiratory rate, even with shallow breaths, they are, if they are conscious and they are able to inhale and exhale, in that case, they are eligible to use CPAP on them. Of course, with other consideration like the blood pressure and so on. So after we check the eligibility, as we know, because the CPAP is a continuous pressure during inhalation and exhalation. So in that case, what do we expect during exhalation? We expect another pressure that force against our exhalation. So I want you to imagine that if you are riding a car and you are just putting your head out of the window, you feel that pressure on your face. This is the same how they feel when you use CPAP during exhalation. So that's why the procedure itself at the beginning is not comfortable. And this is expected, and this is one of the main, let's say, challenges of CPAP. But at the same time, the requirement of the CPAP is needed. So what do we need to do in this case? In this case, first of all, we need to start with 5 centimeters of water according to the protocols. Like according to the majority of global protocols, we start with 5 centimeters of water, and we don't head tighten the head harness. Why? Because let me show you one moment. So once we decide that the patient is eligible for the CPAP, first thing we need to do is to find a good size for the mask that covers the bridge here of the nose, and at the same time it covers the lower part of the lower lip. So in case if you have a patient like a large patient, in that case, of course, we need to use the large size, but in the majority of adults, we need to make sure that not to use large size for all patients, because the anatomy of the face is more important than the size of the head. So we need to make sure that the anatomy that covers from the bridge here of the nose until the edges of the mouth and below the lip. So this is how we make sure that there is no leak on the mask. So once we decide about the size of the mask, then we start with 5 centimeters of water. Why? Because in that case, the pressure is low. So in this case, before starting the procedure, we need to explain that to the patient, that you will face like a high pressure that can be against your exhalation. Why? Because they need to understand what's going on here, and that will reduce the anxiety, because in case if they feel the high continuous pressure, they will be anxious, and in that case, it will reduce the tolerance of the CPAP. And always keep in mind that tolerance is the key of the success of the CPAP. So that's why we start with explanation about the procedure. We explain the concept of CPAP briefly, that it will be a continuous pressure during inhalation and exhalation. So if you feel that the exhaled breath, that once you exhale, if it's conflict with the flow or the pressure, it's fine. You need just to breathe smoothly. Try to calm the anxiety of the patient. And then ask the patient to hold it by themselves. Why? Because this will help them to feel how the pressure will be. And once they are adapted for 1 to 2 minutes, for example, in that case, you will be able to fit the head harness and to make it tight in a way that it prevents any kind of leak. So always keep in mind that the majority of leaks, they come around the nose. So in that case, during inhalation or exhalation, you may feel some flow that goes toward the eyes. Or it could be also, if the size of the mask doesn't cover the edges of the mouth, in that case also it may lead to have some leaks on sides. And also for like the lower part of the lip as well, it needs to be blocked. Another step. So once we start with 5 centimeters of water, and now the patient is adapted and well tolerated to the CPAP, in that case, you will check what? We need to check, first of all, the oxygen saturation. So if 5 centimeters of water is well tolerated to my patient and the oxygen saturation is within the accepted range according to the case, in that case, we don't need to increase the pressure, because any increase of the pressure, you will face a conflict with the patient. Because if the oxygen saturation is still like within 2 to 3 minutes, for example, is still not optimal, in that case, after 2 to 3 minutes from starting the ventilation, the CPAP, you may add another 2 or 3 centimeters of water. Don't jump to 10 immediately, because this is the way how we could make the patient adapt that continuous pressure. So in that case, you check if that 2 or 3 centimeter, the additional 2 or 3 centimeters of water are accepted in terms of the oxygen saturation, we leave it the same way, and we keep monitoring the mental status and the consciousness of the patient. Later on, if 8 is not enough, we increase it to 10 after 2 to 3 minutes. In that case, until you reach the maximum allowed level of CPAP in your protocol. What's the maximum level you reach? Is it 10 or 15?
10.
Any answer, guys? Is it like the maximum? Is it 10 or 15?
10.
10.
All right. So until we reach the maximum level of CPAP. So in that case, if the oxygen saturation is acceptable and within the range of good oxygen saturation, in that case, we keep it the same way. And if the patient cannot tolerate 10 centimeters of water, in that case, we switch to BiPAP to make it easier to have 2 levels of positive pressure for inhalation, a higher level for inhalation, and a lower level for exhalation. Let me show you that. So if we go to CPAP, and I set the CPAP at 7, right? So in that case, the continuous positive airway pressure will be at 7, and it will be maintained and continuous. Let me increase it to 10. So now I'm having 10 centimeters of water as, let's say, the maximum level of CPAP. What do we expect in terms of the peak airway pressure on live monitoring parameter? It's supposed to be matching. Why? Because this is the highest pressure that we deliver during the ventilation on CPAP. So it's supposed to match each other. Let's say, with small differences, it's fine, but it's supposed to be within that range. In case if you feel like your patient cannot tolerate 10 anymore, and they are suffering because of the high level of CPAP during exhalation, in that case, we lower the CPAP to 5 to make it easier and to make the baseline pressure for inhalation and exhalation to be 5. So it means that during exhalation, the patient will face only 5 centimeters of water for CPAP. Once we set CPAP at 5, in that case, we add PSV, or pressure support ventilation. We usually start with 10 centimeters of water on PSV, 10 to 15. This is acceptable for inhalation. In that case, what you will notice here, we will notice different stuff. So pressure support ventilation, it helps patients' inhalation. So the ventilator will deliver some pressure support for the patient during their own spontaneous inhalation. So once the patient inhales, the ventilator, using the trigger sensitivity, same way as from here, it will give the reading for the trigger. So in that case, the ventilator will deliver the pressure support ventilation on top of what? Of the baseline pressure. What's the baseline pressure here? Is the CPAP pressure. So that's why, what do we expect for inhalation? If the baseline is 5 and we added PSV at 10 on top of the 5, so in that case, the peak airway pressure will be at 15, which is the maximum airway pressure during inhalation and exhalation. If we set the PSV at 15, what do we expect here? We expect 20 centimeters of water. So this is the pressure for inhalation. And what's the pressure for exhalation? It's the CPAP, because for exhalation, it will be maintained as a baseline pressure. So what happens here also, not only with the pressure, what happens to the exhale tidal volume? If you remember, when we were at 5 centimeters of water on CPAP, this value showed us around 70 to 100 breath. So in case if you have patients who are suffering with high respiratory rate or tachypneic, but with a shallow breath, in that case, in live monitoring parameters, we will see a high rate of respiratory rate. It will be high because they are tachypneic. And the tidal volume, the exhale tidal volume here, it will be shallow, it will be very low. So it's not that efficient. So we could check the exhale minute volume. If it's low, let's say 3, for example, for a big adult patient that's supposed to breathe, for example, 5 or 6 liters per minute, in that case, we could switch to bilevel. Why? Because during inhalation, that pressure support, it makes it easier for the patient to inhale. So that's why the tidal volume, the exhale tidal volume, is more efficient, which make it close to what it's supposed to be for adult, 500 ml, 600 ml. So that's another reason for using bilevel. Any questions so far, guys? So basically, that's all for today. I would like to get if you have any questions related to the topic or unrelated. I'm here to help you. Again, what you are experiencing now is completely understandable. It just needs more practice and experience. And in any case, if you experience any unfamiliar points, it's totally fine, and we are here to help you. Just feel free and reach out to me directly if you want. You can take my email and send me your questions or concerns. or in case if you need more additional educational materials or additional trainings, I'm also here to help you.